is known far and wide for his Santa Fe Osteoporosis event that he has every summer. He's known as a leader in the world of osteoporosis, but he's also been a great supporter of rare disease. And it is, as I say, a huge, huge pleasure and honor to welcome him. And frankly, I think you may have figured out he really stepped up because we've had illness once again and needed to adjust our schedule. So he's a particularly special person and rescuing us in a pinch. And so it is with the greatest warmth and thanks that I welcome Dr. Mike Lewiecki to be our speaker today.
Well, thank you very much, Laura. And I'd like to thank you and the team at the OI Foundation for doing such a fabulous job of running Rare Bone Disease Echo. It's been a remarkable success, and I'm really pleased to have it doing so well. So I've been asked to speak about bone turnover markers with a focus on rare bone diseases. This is my disclosure. And these are the objectives. I'm going to just talk about bone turnover markers in general to begin with. Review what we know about in osteoporosis, where most of the information on bone turnover markers is housed, and then talk about some of the rare bone diseases where it may be helpful in managing patients. So this is what bone turnover markers are as commonly defined, and that is enzymes secreted by osteoclasts and osteoblasts and structural proteins or their fragments secreted by osteoblasts during bone formation or released by degradation of the collagen matrix of bone during bone resorption. And these are what I'll call the traditional bone turnover markers. They're classically divided into bone resorption markers and bone formation markers. I've highlighted the ones that have been identified as the reference bone turnover markers, at least for osteoporosis, for resorption and formation. So that is CTX and P1NP. Others that have more historical significance than current significance, but are still being used by some individuals and even in some trials, and that is NTX, pyridinoline, deoxypyridinoline, and TRAP5B, which in the US is not available commercially as far as I know, but maybe at some point. The other bone formation markers are P1CP, which I think is used much at all. Alkaline phosphatase, which is one of the go-to markers because it's part of the standard chemistry profile that we have here. A bone-specific alkaline phosphatase, which can be ordered separately, and osteocalcin. So more on the reference markers. CTX is a non-helical peptide fragment of type 1 collagen containing cross-linking regions released into the systemic circulation during bone resorption. It can be measured both in blood and urine, although I think most of us do it in the blood. Serum CTX accumulates as renal function declines, and it's not dialysable and not useful in patients with CKD, or at least severe CKD. It comes in two flavors, alpha and beta. So alpha is the native CTX, which is not measured in any commercial assays that I know of. So when we order a CTX, what we get is a beta CTX, and often the beta is dropped and it's just referred to as CTX. P1NP is normally measured in blood, and that also comes in two flavors. One is the total P1NP, which is the Roche assay, which is not approved by the FDA in the United States. That measures the intact molecule plus monomeric fragments excreted by the kidneys and does accumulate in CKD patients. So total P1NP is generally not considered to be useful with CKD. the intact P1NP, which is the one that is the standard in the US. So if you order a P1NP in the US, I assume that you will get an intact assay. That is valid for CKD patients as far as we know. So if you're concerned about bone remodeling rate in CKD patients, that may be helpful. This is the classical cartoon that describes bone turnover markers of all sorts. I'm not going to go through this in detail because you've all seen this before, but here's where P1NP shows up and CTX is over here. Now I'm going to show you the real cartoon. And this comes from my late colleague and friend, Dr. Sergio Ragi from Vitória, Brazil. He came up with this many years ago, and what you see on the right-hand portion is the guy with the jackhammer that is resorbing bone, creating havoc with bone resorption pits, and as a result, CTX, a marker of bone resorption, is released. And on the left-hand side, you see the worker guys who are the osteoblasts that are filling up that divot, and as a consequence, P1NP is produced, and that's what we measure when we order a P1NP. So I think this describes it very nicely. Aside from the traditional bone turnover markers, there are others that we might call novel bone turnover markers or biomarkers, perhaps. You see the list of them there. I'm not going to talk much about any of those except to mention FGF23. And the reason is that limitations have been very well identified in recent published articles, and the limitations include lack of standardized assays and reference intervals, not well-established relationship with fracture risk, not fully established predictive value for clinical outcomes. And as a result, the clinical use of these markers needs further study. So that's where we are today. Bone turnover markers are terrifically useful for helping us to understand the mechanism of action of drugs that we use for osteoporosis, and these same drugs may be used for rare bone diseases as well. So in the upper left-hand panel, you see the typical pattern for teriparatide, where P1NP rises very quickly, peaks out after about 3 months, and then slowly declines. The rise in NTX here is slower and not so high. So this difference between resorption and formation has been called by some the anabolic window. In the lower left, you see a totally different pattern with alendronate, where there's a decrease in both P1NP and NTX. It appears to reach a low point at about 3 months or so. With denosumab, which is not shown, there's a more profound decrease in both of these markers, with a little bit of an uptick at the end of each 6-month dosing period. In the upper right-hand corner, you see the very different pattern of bone turnover markers with romosozumab, where there's uncoupling of formation and resorption with a rapid increase in P1NP that peaks out at about 1 month after dosing, a CTX that goes down slightly initially, and after about 6 months or so, both return to baseline with a slightly higher P1NP than CTX, and this represents the idea that romosozumab acts more like an antiresorptive medication after 6 to 12 months. So a clinical question that commonly arises is this: do pretreatment bone turnover markers predict fracture risk reduction with bisphosphonates? And the answers are a little mixed. On the left-hand side, we see a post hoc analysis with Doug Bauer as the first author, looking at the FIT trials in over 6,000 women. And there was a correlation between high baseline P1NP, but not bone-specific alk phos and not CTX, and reduction of non-vertebral fractures, but not vertebral fractures. So it's a little bit too nuanced, I think, to strictly adopt that for clinical use. Now, with another bisphosphonate, risedronate, the answer is no, but I qualify that with maybe. This is a post hoc analysis of the vert and hip studies in about 1,500 women. And here, there was no correlation between baseline urinary deoxypyridinoline and vertebral fracture at 1 year and 3 years. However, perhaps the wrong bone turnover marker was chosen here. And it's possible that if another bone turnover marker had been used, a different sort of relationship might have been found. Now, what about teriparatide? Do pre-treatment bone turnover markers predict BMD response to teriparatide? And the answer in this study, at least, is yes. So this was a post hoc analysis of the fracture prevention trial in about 1,600 women with postmenopausal osteoporosis. And here we see highlighted in the box at the bottom the positive correlation between baseline bone turnover markers and BMD response, which was most robust for P1NP, P1CP, and NTX. And that is with the 20 microgram dose, which is what's approved for clinical use. So the takeaway I have from the data that we currently have is that the idea that antiresorptive drugs work best in patients with high baseline bone turnover markers and anabolic drugs work best in patients with low baseline bone turnover markers, which seems very intuitive and reasonable. This is not strongly supported by the data. And although I may look at bone turnover markers before starting treatment, it's certainly not a strong part of my treatment considerations. Now, what about post-treatment bone turnover markers? Do they predict fracture risk reduction? So here's some data with bisphosphonates. Again, this is with Doug Bauer as the first author, with a meta-regression of 14 randomized controlled trials, 4 bisphosphonates and 3 SERMs, and many patients. Bone turnover markers were assessed and included CTX, NTX, P1NP, and bone-specific alk phos. And here, there was a strong correlation with bone-specific alk phos and P1NP changes and vertebral fracture risk reduction, but not for non-vertebral fractures and hip fracture. And there was no significant correlation between CTX and NTX changes and any fracture type. And it's an interesting finding because I think many times in clinical practice, we tend to be using the CTX to try to monitor treatment effect. But at least in this study, there's a lack of data supporting doing that. What about teriparatide? Well, there is pretty good evidence, I think, that increases in bone turnover markers represent a future BMD response with teriparatide. So this is looking at the fracture prevention trial. A wide range of bone turnover markers were measured, but the best correlations were with P1NP and P1CP. So with the approved 20 microgram dose, P1CP increase at 1 month, P1NP increase at 3 months, were both highly correlated with lumbar spine BMD increase at 18 months. And I sometimes do this if there's any concern on my part or by the patient's part about whether a patient is responding to treatment or not. This is a good way to give us both an additional feeling of comfort that we're accomplishing our mission. The takeaway here, I think, is that bone turnover markers, especially markers of bone formation, have a role in evaluating response to antiresorptive and anabolic therapy. So we have some statements from the IOF-IFCC Working Group and Joint Committee. The most recent in 2021 referenced here, that CTX and P1NP are the preferred reference markers, both in clinical trials and clinical practice. The committee tells us that bone turnover markers cannot be used to diagnose osteoporosis. They can't predict the risk of O and J. They cannot determine whether to initiate treatment with antiresorptive or anabolic. And they state exactly that anti-fracture efficacy is largely independent of baseline bone turnover markers. They cannot be used to predict the rate of bone loss in individual patients or predict fracture risk in individual patients, although they seem to do that in groups of patients. And I have to confess, I sometimes will consider bone turnover markers when I'm thinking about the rate of bone loss or fracture risk, but certainly there's no robust evidence that that is appropriate. They're potentially useful to monitor the offset of effect with a bisphosphonate holiday or denosumab discontinuation, either before or after follow-up treatment with zoledronic acid, and most useful to monitor treatment effect with a bisphosphonate, teriparatide, or abaloparatide, and to assess adherence to therapy and absorption of oral bisphosphonate therapy. So these are some practical considerations that have been identified for patients with CKD. The best bone formation markers are bone-specific ALP phos and the intact P1NP. Resorption marker, if you have it available, is the TRAP5B. Reference intervals are clearly needed to interpret single values, and least significant change is needed to interpret change in therapy. And the median of premenopausal reference intervals is commonly used as a treatment target for antiresorptive therapy, at least in women. And it's not entirely clear how well this works in men, and I'll show you the reason for saying that in just a minute. So Richard Eastel has come up with a pragmatic approach for monitoring antiresorptive therapy with bone turnover markers, and I believe in his clinic this is almost always alendronate. With CTX, he makes an assumption based on clinical trial data that the LSC is about 100 nanogram per milliliter, that the healthy premenopausal mean is 280, and that an optimal treatment response is a decrease of more than 100 to below 280 at 6 months. And if P1NP is used, his assumptions are that the LSC is about 10 micrograms per liter. The healthy premenopausal mean is about 35, and the optimal treatment response here is a decrease of more than 10 and going below 35 at 6 months. The treatment target is less well documented than the LSC approach, but it's helpful when there's no baseline value, which is sometimes the case if you're not thinking about this in advance. And he evaluated this in a report of a small number of patients, 34, mostly female, who were monitored with P1NP in the general practice setting, and 79% met criteria for treatment response. There were 7 patients who were considered to be suboptimal responders, which, as always, suggests the need for reevaluation and consideration of a change in therapy. And of the 7, 3 were found to have an explanation, poor compliance, having surgery, or incorrect timing of the sample. And there are certainly advantages to using P1NP over CTX in that fasting and time of day do not make too much of a difference with P1NP, and it can simply be drawn at the time of the clinic visit without requiring possibly another visit to the lab early in the morning in a fasting state. What about monitoring anabolic therapy such as teriparatide? Well, These are the assumptions. LSC for P1NP is 10, healthy premenopausal mean is 35, and the upper limit of normal is considered to be 69. So the optimal treatment response to teriparatide is an increase of more than 10 at month 1 and 3, and above 69 on at least one occasion. So this was tested in a group of 91 patients, mostly female, all previously treated with a bisphosphonate and using P1NP. And 95% of these patients responded with an increase of more than 10. 66% got to a level above 69. And again, the protocol in the clinic is that suboptimal response suggests the need for reevaluation and consideration of a change in therapy. And we can talk more about what that means if you want to. So reference values are important, and here is a nice study that you may or may not have seen that shows very distinct patterns in the changes of bone turnover markers over time in men compared to women. So what you see in women is fairly stable bone density at reasonably low levels up until the time of menopause, when there's a rapid rise in bone turnover and a subsequent, a little fluctuation, but still above baseline. This dashed line here represents the approximate healthy premenopausal mean, and the oval represents the time in a patient's life where we're probably most likely to be using bone turnover markers. Now, men, on the other hand, have a much higher baseline bone density at the younger age groups, and at the same time that women are rising at the time of menopause, men's bone density tends to dip down a little bit and remain below women for the rest of a lifetime. So if you're using a premenopausal female mean of 280 or 300 as a treatment target, it's quite possible that the man will already be there before treatment, and it might lead you to believe that perhaps we should have a different treatment target for men, but I don't think there's any consensus on what that should be. Now, here's a similar pattern for P1NP in a similar population. And because of coupling of resorption and formation, it follows the same pattern that we saw with CTX. Again, we're going to focus on this older group when we're most likely to be using a P1NP. This dashed line represents the mean for premenopausal women. And actually, it calls into question whether this value is an appropriate target for men as it is in women. This line at the top represents the upper limit of the normal range at 69, and this would potentially be a target if you're treating with teriparatide. So that leads us to what the heck does this have to do with rare bone diseases? So I undertook a highly unscientific poll of 10 rare bone disease experts, some of whom I think are with us today. And I got 8 responders for an 80% response rate. And I asked the question, do you find bone turnover markers useful in the management of patients with rare bone diseases? And these are just a summary of the responses I got from the 8 responders. And that is that they're generally not helpful for diagnosis, with exceptions, as with ALP for HPP, for Paget's disease, juvenile Paget's disease, and osteomalacia, that they're helpful in understanding the pathophysiology of rare bone diseases, particularly for disorders of the rank L, rank OPG system, and FGF23 for evaluation of hypophosphatemia. They can be a marker of disease activity for fibrous dysplasia, McCune Albright syndrome, and Paget's disease. They may be helpful in selecting therapy, such as avoiding bisphosphonates if bone turnover markers are low, useful for monitoring therapy by the same token that we use it for osteoporosis. And finally, from a colleague that you probably all know, he tells me that results are sometimes interesting and helpful to understand the condition. But this is paraphrasing what his response was. I have never made a diagnosis and never changed treatment because of bone turnover results. And that may be the feeling of many of you here. I went back a long way to look at the correlation between alkaline phosphatase and histologically proven osteomalacia. And I came up with this from 1982. And you might recognize some of the names of the authors here. This was a retrospective study of 50 patients with biopsy-proven osteomalacia and 50 age and sex-matched controls, and another study that was a prospective study of 62 patients with suspected osteomalacia, of which half turned out to have osteomalacia on bone biopsy and 31 did not. And the conclusion was of the tests that were evaluated, calcium phosphate and alkaline phosphatase, ALP was the single best screening test, although false positive rates were high. And you see false negatives and false positive represented at the bottom right. So it's telling us, I think, that when you suspect osteomalacia, having a normal ALP certainly does not rule out that diagnosis. And if your index of suspicion is very high, you might want to go on to consider bone biopsy. Well, of course, for hypophosphatasia, low ALP is the biochemical hallmark of the disease. We need to be sure that we're using the correct age and sex matched reference data. I think we would all probably agree that low ALP with typical history, clinical and radiographic findings is sufficient for making the diagnosis. High substrates such as PLP, PEA, and PPI are confirmatory, but they're not necessarily required. And mutation of the TNS-ALP gene is confirmatory, but there certainly are cases of HPP that do not have a recognized mutation. When we see a low ALP, we need to consider the differential diagnosis, and those that are most common are listed on the left. And at the top of the list is denosumab, and my experience, by far, the most common cause of low ALP is denosumab. And in fact, we've accumulated a series of 60 or more patients with low normal baseline ALP who went down into the range below the reference range after treatment with denosumab, and it got to be so common I stopped keeping track of it. It may also be seen with some of the potent bisphosphonates, especially zoledronic acid. I have seen it on rare occasions with glucocorticoid therapy. On the not so common side, hypophosphatasia is the first thing that comes to my mind, but it's certainly not the only thing. And when you're considering a workup for low ALP and it's not hypophosphatasia, you certainly need to at least keep in mind, in the back of your mind, all of the other possibilities and do an appropriate evaluation for those. So these are some of the conundrums that I find with low ALP. When a patient treated with denosumab has low ALP, is it due to the expected antiresorptive effect, or is it HPP that's been unmasked by denosumab? What I typically do in those situations is order a B6 level. Most of the time it's normal. If it's high in that situation, I may go on to further evaluation. And also, if a postmenopausal woman has severe osteoporosis and low ALP due to mild adult HPP, should antiresorptive therapy with bisphosphonates or denosumab always be avoided because of concern of increased risk of AFF, and that risk may be increased by HPP itself and possibly by the antiresorptive therapy. And I have used antiresorptive medications in some HPP patients when I feel that the risk of fractures from having severe osteoporosis far outweighs the risk of having an AFF by giving treatment. But that's another topic for discussion, and there's probably plenty of differences of opinion on that one. There's Paget's disease of bone, thinking more about ALP. This is a focal disorder of bone metabolism, usually in older adults, more common in men and Europeans, and at least in my experience, it's become very rare across my practice and the rest of the US from speaking with colleagues. Bone turnover markers are useful for diagnosis, evaluating the extent of disease, and assessing response to therapy. ALP is the first-line biochemical screening test, and a high ALP with normal liver function studies may lead to a radiographic diagnosis and then a nuclear bone scan to assess the extent of disease. Biochemical treatment target is usually a normal ALP. However, about 15% of patients with active Paget's disease have a normal ALP. So when clinical suspicion is high, you might consider measuring other bone turnover markers, perhaps a P1NP or a CTX. In one population-based study in Holland, about 11% of patients over 55 with a high ALP and normal LFTs had radiographic evidence of Paget's. So certainly a high ALP and ALP and normal LFTs might be reason for further evaluation. Now, there are different causes of a high ALP, of course. We typically divide these into hepatic and non-hepatic forms. Focusing on the non-hepatic side, it may be physiological for the reasons you see here. It may represent high bone turnover, which could be from healing fractures, osteomalacia, Paget's disease of bone, osteosarcoma, bone metastases, and so forth. So these are things that we need to consider in our evaluation of these patients. Juvenile Paget's disease was mentioned by one of our survey responders. This is an autosomal recessive osteopathy that's characterized by rapidly remodeling woven bone, low BMD, fractures, and skeletal deformities. It's caused by a loss of function mutation of the gene that encodes for OPG and is sometimes called OPG deficiency disease. This is characterized by extremely rapid bone turnover, represented by very high ALP and other bone turnover markers. In looking into this, I discovered that this has been reported in Navajos in the Southwest USA, where I am. And as many as 1 in 100 Navajos, and we have many Navajos on the reservations here in New Mexico and in Arizona, may be heterozygous carriers. What you see on the right-hand side is a report of a 2-year-old girl with juvenile Paget's disease who presented with bowing of both legs, lower limb pain, and very, very high ALP. In fact, it was over 2,700 at the beginning. She was treated with bisphosphonates, which reduced the ALP, improved bowing and bone pain, and she ended up reaching adulthood with normal height and no functional impairment. So it seems to be a good success story for bisphosphonate therapy and the ALP seems to be a reasonable marker of the effectiveness of this medication. Our responders also mentioned disorders of rank L and OPG. This is a case of a 10-year-old girl with a mutation in the gene encoding for rank. She had early onset hearing loss, resorption of permanent dentition, low bone density, and increased bone turnover markers. She was treated with Zol, followed by alendronate. And what you see on the graph on the right is a very rapid decline in ALP in response to treatment, as well as a decline in urinary NTX. She happened to have initial hypocalcemia, but there was an increase in bone density and improved bone turnover markers while dental resorption persisted. So bone turnover markers appear to be reasonably good markers in this case. Osteopetrosis is a sclerosing bone dysplasia with reduced osteoclastic bone resorption and high bone mass. In the absence of genetic testing or typical radiographic findings, elevated levels of the biomarkers that you see on the right may be helpful in that they're correlated with autosomal dominant osteopetrosis with CLC and 7 mutations. They're not correlated with disease severity, and normal values do not rule out a mutation of this particular gene. So they may have some benefit, although somewhat limited at the same time. With fibrous dysplasia and McCune Albright syndrome, bone turnover markers may be helpful. This is a mosaic disorder leading to one or more discrete expansile skeletal lesions with bone pain, fractures, and disability. Bone turnover markers have been evaluated as markers of disease activity to predict progression of disease and to monitor treatment effect. Here you see evidence from an NIH study from Mike Collins and colleagues that bone turnover markers, including deoxypyridinoline and bone-specific ALP not shown here, were all significantly correlated with skeletal burden scores. Bisphosphonate treatment with pamidrodate in 5 of these patients decreased ALP, but did not change the skeletal burden scores. So interesting, the lack of correlation there. Osteocalcin, interestingly, has been correlated with disease progression for fibrous dysplasia. This is another NIH study with 31 children. They had baseline and follow-up bone scans, skeletal burden scores, and bone turnover markers. Here we see that osteocalcin was nicely correlated with disease progression, and this suggests that perhaps osteocalcin may be useful for early identification of children in need of aggressive treatment early on. So I'd like to have more data on this, but there is potential here. There's an age-related decline of bone turnover markers with fibrous dysplasia, as you see here. And this holds for ALP, osteocalcin, and NTX. However, the age-related decline in bone turnover markers was not altered by treatment with bisphosphonates in this study. Bisphosphonates did not prevent progression of disease in children, and pain was more frequent and more severe with advancing age despite bone turnover markers dropping. So I think this illustrates that the pathophysiology of pain with fibrous dysplasia is complex and not entirely related to bone turnover or disease activity. And this is hot off the presses. This is just published, I think, in the last couple of weeks in New England Journal as a letter to the editor. Some of these images were presented recently by Mike Collins on rare bone disease echo. So there were 8 women in this study. They received 6 months of high-dose denosumab, 120 milligrams every 4 weeks with loading doses at weeks 2 and 3, followed by zoledronic acid, and then followed for 8 months. What you see here is that there is a robust decline in most patients in P1NP and CTX. You see in the PET-CT images that there is improvement in lesion activity. There was a rebound increase in bone turnover markers with hypercalcemia in some patients after DMAB was discontinued. FGF has been classified as a bone turnover marker by some, and in any case, it's used to evaluate patients with hypophosphatemia from renal phosphate loss. And you can look at non-FGF mediated and FGF23 mediated categories. And we often focus on some of these, XLH and so forth with family history. You can have those diseases without a family history, but also tumor-induced osteomalacia, ferric, carboxymaltose infusions may cause this, and fibrous dysplasia. But the question arises, which FGF23 assay is best, and what's the cutoff between high and normal? So here is another NIH study in 434 patients, some with low phosphate, some with high phosphate, some normal. And what they were doing is comparing intact FGF23 with C-terminal FGF23. And the bottom line of this study was that the intact FGF23 assay was recommended because of having greater sensitivity, and they recommended using a cut point of greater than 27 picogram per milliliter for a high FGF23. They followed that with saying that the C-terminal FGF23 is adequate if you're unable to get the intact value, with a different cut point of 90 for TIO, while levels that are borderline between 45 and 90 should prompt measurement of intact FGF23. What about OI? Well, this study concluded that although the use of biochemical markers has not been formally evaluated in OI, available clinical trial data in OI suggest similar bone turnover marker responses to therapeutic intervention. So perhaps we could use this in much the same way as we do with osteoporosis. So this is my last slide to summarize. CTX and P1NP are the preferred bone turnover markers in clinical practice and clinical trials with osteoporosis. The greatest clinical utility is to monitor the skeletal effects of treatment. These provide insights into the mechanism of action of drug treatments, and traditional bone turnover markers and some novel bone turnover markers are potentially useful in some patients with some rare bone diseases. So thank you for your attention. I probably can't answer